Okay, welcome to Spine Conference. Today's conference will be on spinal instrumentation device failure, and this is a different format where I have just one other person in the room, Dr. John Antonitis, who's not a spine surgeon, but he is an orthopedic surgeon.
Great to be here.
All right.
It's like those podcasts.
Yeah. Okay. So this is an illustrative case. This is a 48-year-old man with low back pain and sciatica. And these images are from January 9th, 2009, so 12 years ago. Low back pain, bilateral sciatica, 48 years old, neurogenic claudication. So every single time he walked, he had pain down his back, buttock, and legs. And his past medical history was just a right L5S1 disc in 1992, which I guess was 9 plus 8, 17, 18 years ago. So physically, a very large man, 6'3", 300 pounds, and no deficits. So do you want to ask any questions about anything else for him?
No.
History? Okay. So here, what do you think of the x-rays? This is a lateral and a flexion view on the right. What are your thoughts?
He's got loss of L5S1.
Yeah, so L5S1 disc is flat. I mean, 4-5 is flat too, right? 3-4 is somewhat flat, mildly. There's a vacuum sign, small anterior osteophytes, and on flexion view, what do you think? Spondylolisthesis? No, very stable, right? Okay. AP view, you see any scoliosis?
Nope.
And sacroiliac joints look pretty normal, right? And extension view is normal. You can see he does have a little bit of vacuum sign when he extends, probably because he has degenerative disc disease, and when he does that, the disc distracts when he extends, and it creates a vacuum. It's a good example of that. So these are the MRIs, and
is that a sign of disc disease when they have a vacuum?
Yeah. So you can when you're anteriorly in the front of the spine, and you remove with a ronger the anterior longitudinal ligament, there's like nothing there. There's like a gap. So what happens, I think, is in vivo is when they extend, they create a vacuum. So here are the sagittal cuts. So you can see decreased signal, bulging, right, at almost every single level. You want to add any questions? So these are all the axial cuts. So T12L1, and this is the spinal canal, T12L1. What do you think? How do you compare T12L1 to L1L2? The canal.
1, 2 smaller.
Yeah, much smaller, probably like 50%, right? And then, I mean, basically I use the spinal canal above as a baseline. So you can see this is at the L2 pedicle. This is basically what a spinal canal should be. And you can see it's about half the size. And then see 2-3 is pretty tight. 3-4 is tight. 4-5 looks like it's his worst level, don't you think? And 5-1, you see here the laminotomy defect on the right. And you can't see the nerve roots well in this patient because he's so big. So I found that large people, they're very difficult to get good resolution on these patients, no matter what. So far, stenosis looks like his worst level is 4-5. 3-4 looks tight. 2-3 is tight. So just to review the spinal canal, this is from Rene Louis' textbook, Surgery of the Spine, which is a really old textbook. It's out of print. I actually photocopied it from Paul Asdurian's copy, and that's how I have a copy. But you can see the spinal canal at different levels has different shapes. And the lumbar spine is mostly round. You see L2, L3, L5, slightly triangular. And this is a very nice article that I want to share with you that I read from Skeletal Radiology 2011. So the typical description for spinal stenosis is you just look at the spinal canal, like you just measure it. I mean, the old school ways, some radiologists just say severe or mild or moderate, and then other times you say, oh, it's 5 by 5 millimeters or 10 by 10 millimeters. But this is a very interesting article because they describe the stenosis as related to the nerve root. So they say, is there cerebral spinal fluid anterior to the nerve root? So you can see here, the spinal canal, you have plenty of CSF in front of the nerve roots. And you see here, you have no CSF around nerve roots. So that's one measure of stenosis. Another one are the roots separated. You see here the roots are widely separated. And here they're not separated at all. Any space between the roots. You can see the individual dots, and here you really can't. There's no space between the roots. Epidural fat. You see here is a nice epidural fat, no epidural fat. That's how stenotic it is. Perineural fat in the foramen. And then you can always do the old way to describe is just cross-sectional area. You can describe how short the pedicles are, and you can describe the angle. But I like this because it's a description of the spinal canal, which helps. So if you go backwards to this guy, you see like here there's very little epidural fat. You cannot see the nerve roots. You see, like even at this level, you see no CSF anterior to the roots, and you see, like compared to T12L1, plenty of CSF around anterior to the roots. So I think, but what do you think of that? Have you ever heard of this before?
Mm-mm.
It's very helpful, don't you think?
Epidural fat pad, I've heard.
Yeah, epidural fat. But all of these all of these people talk about it, but this article made a grading system. And I'm not so sure if I agree with having a grading system, like it's like kind of like formulaic. But I think it's something to think about. And I just describe that in my note. Okay, so this man, he has stenosis, no instability. What do you think we should do? So I just did a decompression.
Mm-hmm.
So I did my typical unilateral laminotomy, bilateral decompression. These are my notes. I approached it from the left side, decompressed L1, L2, L1, L2, L2, L3, L3, L4, L4, L5. And then I tunneled underneath. This hatch is just my notes to myself that I tunneled underneath and opened up the spinal canal bilaterally. So his case, 200 cc's blood loss. He didn't, it wasn't, I think it was like 2 or 3 hours. And clinically, he did fantastic. And just to give you a review, unilateral laminotomy, bilateral decompression, you decompress it from one side, but you open up both sides of the spinal canal. This is like a full laminectomy. You take the whole lamin off. And this is a bilateral laminopharaminotomy where you keep the posterior spinous process intact, but you can decompress both sides. But doing this procedure, you have to open up both sides. The benefit of the ULBD is you just open up one side, so half of the musculature is intact. It just gives you an idea how you do it. You do it one side, and you tilt the table in the microscope and do the other side. So that's just basically the ULBD. So you can see here the laminopharaminotomy defects. See that? See all those little holes? And he had an excellent clinical result, super happy. Went back to all of his physical labor, everything. So it's kind of a, for him, kind of a small operation, 4-level decompression. He was very happy, 2009. So in 2013, he went to his primary, do you have any questions so far?
No.
Okay. In 2013, he went to his primary care physician with back pain, and his primary care physician ordered an MRI, and this is just the MRI. And you see here, 12-1 looks good. L1, L2 definitely looks better. Again, this is 4 years post-op than it was pre-op. There is CSF about the nerve roots at 2-3. 3-4 looks kind of tight. 4-5 looks pretty good. Plenty of CSF about the roots. Again, it's not a good picture because of his size, but it's kind of interesting. And then he got better, but then
Can you go back to one?
Yeah.
Did it get tighter at 3-4 from the facets? They
Yeah, exactly.
So that's the downside of doing them.
Well, that's the downside of not fusing.
Right.
Because when you fuse it, that doesn't happen. But fusion is a much bigger surgery. But exactly, see how the facets hypertrophied, and they hypertrophied in 4 years. So
Part of the disease.
Exactly, it's part of the disease. And the disc kind of, I think. Let's compare the disc. See, the discs got flatter too. See that? That's in 08. Somewhat, maybe not. A little bit flatter. Okay, but he did get better from this from 2013. He was treated non-operatively with steroids, pain pills, therapy, got better. But then he returned to me in 2018, so this is 9 years from his index procedure, and he had severe low back pain and sciatica. And it kind of looks similar, but here are the axial cuts. Again, they're poor images because he's big. But you should see, this is T12L1. This is what the spinal canal should look like at every level. You see 1-2 is kind of stenotic. 2-3 is not too bad, right? But 3-4 is definitely stenotic. 4-5 is not too bad, right? You do see CSF, and 5-1's always been normal. So he has recurrent stenosis. It looks like his worst level is 3-4. 1-2 is pretty bad. So at this point now, what do you do? He's had the ULBD decompression. You can, the options are, ask me a question if you have any questions. The options are you can just revision decompression or you can fuse him. Now he's a big guy. So a fusion's a big deal for him. And you would probably, you'd have to fuse almost the whole lumbar spine.
You want to get flexion, extension, x-rays to see if you
I did. He doesn't shift.
So you could just do decompression.
Yeah. So, right. So he did not want a big operation. Like he's a laborer. And he said, I want the least amount of surgery that'll fix this. So the discussion, he's an intelligent guy too. He understands things. So the discussion was we can just do a full laminectomy, which should open up the spinal canal, should be fine, or a full laminectomy with fusion, which is much bigger surgery. And he elected to have just a revision decompression because he was stable. So he had a full laminectomy, revision full laminectomy, L1 to L5. I opened up the spinal canal very widely. It took 4 hours because he's a big guy and he's very stenotic. And you can see like a full laminectomy.
What did you see on the left side from the old portholes? Did they fill in with bone?
Yeah. And there's a lot of scar. There's a ton of scar. So it did because the facet's hypertrophied, like you said, and it digs into the spinal canal. And it's not only the facets, it's the facet capsule, which is like a synovitis, like in a knee replacement. So I did a full laminectomy. This gives you an idea of full laminectomy, removing the whole lamina posterior spinous process. And you can see here the post-op clinical result, a really wide spinal canal. And side view, he has always been stable, and he felt great. He says, my back feels better, my legs feel better, I'm fine. So 2 years later, he comes back with the same problem, but this time it's worse. This time he has severe weakness. On the right side, his hip flexors are 2 out of 5. His quads are 3 out of 5. He's falling, and he says his legs don't work right. X-rays, as usual, have shown no instability, but you can see here, look at the lamina here. This is just 2 years. Look at the lamina here. You see the laminectomy here, the space, and then look at the laminectomy here. It grew in 2 years, which is interesting, right? That doesn't happen usually. Usually you do a laminectomy, you never see those people again. So this guy, and you have any, interrupt me if you want to say anything, but this guy I think is he's a special case where he's extremely hypertrophic osteoarthritis.
Yeah. You can see on the lateral, he has
he's got osteophytes, yeah.
That connect.
So he's got very progressive disease. Yeah. And the sagittal cuts are not so helpful, but what?
No, I was just thinking, it happens in joints. You get people hypertrophic, they get a lot of HO around them. Sometimes they get HO around the surgery area. You can start them on NSAIDs right after surgery to decrease that,
Never thought about that in spine. If you
the high-risk people.
And
the real high-risk people, you can radiate, but indocin or anti-inflammatories.
I never even thought about radiating.
Or giving NSAIDs.
Lumbar joint disease. NSAIDs are easy to give.
Yeah. They said
for how long?
I think a couple of weeks. You can give Celebrex. I think the COX-2 inhibitors have shown to help. I think even the COX-1, there's data, especially in hip scopes. Naproxen is just as effective.
For heterotopic ossification.
For HO, preventing HO. And then obviously indocin, which is a stomach unfriendly one. But
this guy's not so much HO. I think he's just like hypertrophic osteoarthritis, like the joints and the capsule.
Yeah.
All right, so now he's very stenotic at 1, 2, 2, 3. 3, 4 is very bad. 4, 5 is open, and 5, 1. So the question is, what do you do now?
Now he gets the fusion.
Now he gets the fusion, right? So and he's got a deficit. So this case was very difficult. It was an 8-hour case just because of his size, and now it's a second decompression. It was extremely stenotic. Had a very small dural tear. These are my notes from the operative case on the right at L3. Initially, I was only going to fuse down to 4 and not do anything at 4, 5, but then I was thinking to myself, 4, 5, has had decompressions twice, and now I'm fusing down to 4. So I felt like 4-5 was at very high risk for deteriorating quickly. So I decided to include it in the fusion.
You have the lever arm. You're going to have a lever arm.
Yeah, the big one. And it's a disease level. So I fused from L1 to L5. Revision decompression at 1, 2, and full laminectomies from L2 to L4, and open it very widely, put screws. And the surgery, considering like the severity of the stenosis, the fact that it was a 3rd revision, and his size, went extremely well. It was just longer than I wanted. And clinically, he did fantastic. Like he went home post-op day 2, he felt great. His weakness, completely gone. I mean, it's like unbelievable results. He was walking around right away. I saw him 2 weeks and he felt great. So these are his x-rays. Do you have any? This right 3 screw, the initial, now in these like revisions, it's really hard to see any anatomy. All the anatomical landmarks are sort of gone. And the initial screw was medial, and then I palpated it. So I decided just not to put a screw in L3 because I've got plenty of fixation above and below. So the x-rays look great. Then I saw him 2 months post-op. The X-rays look great. So what's important in this side view? You see the tulip of the screw, and the screw cap is all fine. And again, and I'm showing this to you because it's going to become relevant soon. You see the tulip of the screw head and the cap is all fine. This is 2 months post-op. Feels great. Super happy. Went back to work as a laborer. And then at the 3.5 months post-op, I had a phone call that he says he feels a noise coming from his back. So what would you do if somebody says that they hear a noise? Is you're crazy or ignore it or?
No, you get an X-ray.
Yeah. So what you tell them to come in and get an X-ray, right? The other thing is, like, as a rule of thumb, is that when you're an experienced attending, if a patient tells you something's wrong with my wound, what do you say? Come in right away, right? Because you always just come in. Let me just see what's going on. Just come in. So he comes in, and I said to the secretaries before I see him, make sure you get X-rays. So before I even came in the room, look at the lateral view. The cap came off. But these look okay, right? And the front view is kind of normal.
Is he fused by now?
No. And he came off because he has motion. And you can see, I also got obliques because you can usually see more details on obliques, although the obliques didn't help us too much. So here he is. So just listen carefully. Okay, go ahead. Oh, it's not working. Hold on. Okay, go ahead. Okay, go ahead. Oh, I know what's wrong. I got to take the microphone off. He's just rocking it. Watch this. All right, let me turn this back on. So, I mean, kind of incredible, right? So, so something's wrong with his screws, and He's got loose screws. And my thoughts, do you want to make any comments?
No, popped off in the rods moving.
Yeah, the rod's moving back and forth. So what does this mean? This means that this one's not making cannot be making noise because it's off. So what happens is these guys are tight, and every time he moves, these caps are slightly tight, and they're riding on the rod. See what I mean?
The rod in the groove is moving.
Yeah, and it's moving up against the cap. Yeah. So this is the Manufacturing Users Facility Device Experience, MAUDE. And you can go online. This is Food and Drug Administration. You can go online, and anybody can report any problem with any device. And actually, I did it. This is not the device I used, but I did it on another device. It took about 10 minutes. And then you can look up, anybody can look up any device and see if anybody has ever made a complaint for a failure. It's really interesting. So I also want to go over locking caps. Like this is some patents of different locking caps that I found on the internet. And this is the exact locking cap that this patient has. So it's kind of, I learned a lot about locking caps with this case. It's kind of interesting. So I'm not going to say the company. I would say company number one. The pitch from one thread to the other thread, like when you go a complete circle, how far down does the cap goes down 1.2 millimeters. That's the pitch. And the thread is a trapezoid. So the theoretical reason for this thing being trapezoid is that it decreases the probability of it backing out. And the threads are just 1 millimeter in deep. So from here to here, it's 1 millimeter. And this drive, the hole for the screw is a T25 hexalobe. I'll show you what it is. And also, you have a torque wrench that snaps at 8 Newton meters. So, I mean, that's kind of like the minimum you need for it to lock. And this screw, this has it's called a Higby cut. It's kind of like an edge that keeps you from cross-threading. And this not relevant to backing out, but it's kind of interesting. So here's another company. I'm not going to say who this is. This is company number 2. Very interestingly, it's like, see how it's not angled. And the point of this is it doesn't, I think it doesn't cross thread as easily. And it's very similar. It's a T25 head. This is another company. It's very similar. Company 3 is very similar to the one I put in. And company 4 is really interesting. Company 4 says they have a proprietary system where their threads are the best. They say that when you have these type of threads, which is like the standard threads that you saw before, it causes the head to splay open. Do you see that? So when you tighten it totally, it splays open and it can loosen, they say. And their device is different. You see how it's different? And they say it creates no force, no outwards force. And it doesn't cross thread. It's kind of interesting, isn't it?
Yeah, it's very subtle.
Yeah, it's very subtle. It's interesting. And then the head is a Torx head. So I think almost every pedicle screw now has Torx heads. So basically, Torx is a aerospace manufacturing company. It's called Textron, and they created the Torx head. That's just it's very difficult to strip, and you can put a lot of force into it. It's a 6-point star pattern. And most of the what are the screws? Do you use screws?
No.
So you don't really deal with in the ways because you do joints, but almost all the spinal screws are this type, like 6 star. It's kind of interesting, right? So do you have any opinions what to do, or I'll tell you what I did? But do you have any opinions or comments or questions?
No, it sounds like you have to put the screws back in.
Yeah. So I mean, I said, do you want? He said, what do you want to do? Do you want to just watch this? Do you want more surgery? I said to him, I'll tell you my opinion. He goes, I'll do whatever you think is best. I think it's best to take him back and tighten it.
Yeah.
Because if you don't tighten it, he'll get a non-union. He's 3.5 months out, and it's actually an easy case. You do it because all you're doing is putting the caps back on. It's 2 stab incisions on either side of the spine, and you don't have to do anything other than that. And if you use the microscope, you can do it through like a hole. So this is through the microscope. I removed the top caps were grossly loose. They're off, but then the next one down, the next one down after that, they were loose. And then when I took the cap off, you see this debris? So this is titanium debris that was sheared off, and it's got soft tissue associated, very similar to the metal that you see in total hips.
Metallosis.
Metallosis, right. And you can see here this line, that's where the cap was rubbing against the rod. And you can see it went like 2 centimeters. It moved a lot. So it's interesting. And this, you need to remove this. Like you can't leave it in because it increases the levels of ions in your blood, like in joints, right? When you revise a joint, you try to remove it all?
Yeah, you take out all the diseased tissue.
All of the metallosis, right?
But you didn't check ion levels.
No, I didn't.
I think you just take out what you see.
Yeah. So the patient did great. I just saw him back. He's like 2 weeks. He feels fine.
Did you put more torque than advised?
Yes. So I torqued it, and then I did what the rep said, white knuckle, is I do it as hard as I can. But the thing is, you can literally break that screwdriver. So you can tell when you can't go anymore. But it's kind of considerable.
Yeah.
So I think I'm going to have to do that.
Especially in high-risk people.
In high-risk people, yeah. And at the top of the construct, especially, if you do more than one. Okay, so do you need other questions or comments? So I was just going to go over how do spinal implants fail? And do you read this book? This guy's hilarious.
No.
It's How to Ruin Your Life. It's a book of how do you ruin your life. Like you get divorced, you cheat on your wife, you spend all your money. It's a great book. So basically in life, you got to know how you can fail. If you know how you can fail, you try to avoid it. So the basic premise of the spinal screws, most of them is there's a rod that connects all of it, and then there's a screw that has a tulip, and then there's a locking cap here that goes down and tightens. So, it's kind of like the essence of it. So this is a case, these I just got these from all sorts of the internet and web and previous cases. So if you don't heal the fusion, it usually doesn't come apart. Usually you get something like this over time. You get halo loosening, where you get motion, and then you can imagine the spine is moving and the screws are staying still, and it creates sort of a hole where the screws are. See that? It's called halo loosening sign. This is from a non-union. So the implants worked fine. It's just that the fusion didn't take. So let's say you don't fuse, but the interface between the bone and the screw is strong, so you don't get the halo loosening sign because it kind of all filled in with bone. So all the force of the non-union from the motion is borne by the screws, and then eventually the screws break because all metal will break. So this is a different mode of failure. If the junction between the bone and the screw is strong, so then all the force is borne by the screw.
So young people probably get this. Osteoporotic.
I've seen very few cases like this. This is like the old school screws. The old screws used to break a lot. I don't see new screws breaking that much.
But you see them loosen in the bone.
I see them loosen in the bone, but I do see some of this. Okay, another one is, the question is, can every pedicle, regardless of size or shape, adequately receive or hold a screw for the duration of the fusion? The answer is no, because just because you bullseye that screw into a small pedicle, the pedicle's weak. And what happens frequently is the screws tear out of the pedicles. You see this? So this screw used to be all the way in perfect, but now it's torn out. This is a very common problem because you put the case in lordosis, and then patients naturally want to go into kyphosis because you try to reduce it, but they go back to where they were and the top screws pull out. So basically, this usually happens like an early failure. Another one is everything is fused, everything is working right, but at one level it doesn't fuse. This is common scoliosis. The rods break because there's motion at that segment, but the screws are strong, the screws are tight, the interface between the bone and screws is tight, but there's still motion, so then the rods can break. The other problem you can have is everything is fine where you did the surgery, but the spine breaks above the previous surgery. And this is more common like osteoporosis patients because it's just too much stress, you know. And the patient wants to move. Like naturally, people want motion, you know. I mean, you can imagine this, like every time this woman goes to tie her shoes, she puts stress. This is another case where this patient had a pedicle subtraction osteotomy. So a lot of stress at just one area and everything fused, but because of the stress of the area, the rods broke. Probably because it never fused. This pedicle subtraction osteotomy, I think it's better when you do PSOs to try to remove the discs so it fuses in the front as well. Because if you don't remove the discs, you're relying all on your posterior fusion. You see that? Because you're in the front anyway, so why not take out the discs? So I mean that's just something to think about. The other ways you can fail is that like an interbody device, if it doesn't heal, it can migrate. So you see, this is an interbody device that migrated posteriorly into the screw, into where the spinal canal is, and this is a problem because they can hit nerve roots. And then the other problem you have is it can migrate into the abdomen, and this is a case where the interbody graft migrated into the abdomen and hit the IVC, the inferior vena cava. The other thing you can have failure of implants is you can have these interbody devices inserted and then they subside. So they basically compress into the bone. And the reason this is bad is because now everything's sort of loose. So I think it increases the probability of a non-union. Yeah. And this is another interesting case that I've seen this patient. She's 83 and she presented to me 3 days before I went to Greece, believe it or not, with you actually. And I felt she needed an occiput to T2 fusion laminectomy. She was grossly myelopathic. And I said, I can't do this for I'm going to Greece. I can't do this. I have to send you to somebody else. So she said, fine. So I sent her downtown and they did not include the occiput. They decided they didn't need to. So she came back to me post-op because her neck hurt and her C1 screws had broken. You see that? And then the C1 screw had eroded and it's in the spinal canal. So the problem with C1 is that it's a very small bone. And I mean, sure, you can put the screw in, but it can't hold the screw because the bone's too small, especially in osteoporotic patients, you know? While the occipital plate is really strong. I mean, I've never seen an occipital plate tear out. But this is interesting too.
And that loosened the way you think.
What?
That loosened the way you thought, you know, with osteoporotic bone around it.
Yeah.
Right.
So the other thing is in the thoracic spine, especially on the left, you also have to be cognizant that, you know, the natural tendency is, well, you don't want to put a screw in the spinal canal, right? So you want to be lateral. Well, if you're too lateral and too long, you can hit the aorta, which can be, you know, catastrophic. It can be, you can kill a patient. Patient could die. You can see the screws in the aorta. And one way to avoid this is on the left, especially, and if especially there's an aorta close to the spine, you always make your left screws kind of short. You see that? So, I mean, I usually, you don't need a long screw. If there's any question, I just make the screws at the 50-yard line of the vertebral body. You see, this is the front, this is the back. So if you kept it at halfway on the left, you're never going to hit the aorta. So that's kind of like a rule of thumb over time that I've used in the past. And this is, I mean, this case obviously screws in the spinal canal, hits the neurological element. It's a big problem. But then if you're lateral to the pedicle, you can hit the nerve root from above. This is the nerve root from above that's already exited, and it's coursing on the lateral aspect of the downwards pedicle. You understand that? So you can't be lateral either in the lumbar spine because you can hit that nerve root. And then the other problem you can have is in the sacral ala. You can hit the L5 nerve root if you're proud on the sacral ala because the nerve roots are there. You see them? So you never think about that, but these are the L5 nerve roots that have already exited the spine, and they're on their way down to the legs of the patient. And you can hit it if the screw's long.
That's a common board question with SI screws.
Is it a board question now?
Yeah, SI screws in trauma.
Yeah.
You get the L5 nerve root.
Yeah.
It sits right there in front of the anal.
So spinal surgery, I just want to go over this. Spinal surgery is very challenging. So I just put this together because I think people should talk about it. Is first of all, is patient selection. I mean, some patients should, like we talk about this all the time. Some patients should just never have surgery, and some people don't have a spine problem. Like they have other problems: depression, opiate dependency, secondary gain. Some patients are just too sick for a surgery, too obese, osteoporotic, their age, and people, especially with advanced age, are very malnutritioned. Cigarette smoking, they can't heal their wounds. Diabetic, get infected. Then the problem with the spine is sometimes it's difficult to know what the pain generator is. So people have hand pain. It may not be a neck problem like for an ACDF. It could be carpal tunnel syndrome. Or sometimes multiple levels are stenotic and causing symptoms, and you do the wrong levels. You ignore stenosis. Sometimes people do the wrong operation. Like I've seen a patient get an ACDF for ankylosing spondylitis fracture. So you have to do the right operation for the right problem. The other reason spine is difficult is the surgical technique is very, very demanding. So if you injure a nerve, like excessive retraction, like during the operation, putting in a cage or something, you have permanent nerve injury. So you have to cognizant of that. You can disrupt the soft tissues. You don't decorticate well enough, and you get a non-union. You put the implants in the wrong position, hit the neurological elements or a joint or the facet above. You don't decompress enough. So, sometimes the spinal surgeries take too long, like an 18-hour case for scoliosis. Those people get problems. Or sometimes spinal surgery is done too fast. I mean, people do a 20-minute discectomy. I mean, you wonder if the decompression was adequate. The other problem with spine is that the post-operative complications are difficult to diagnose sometimes. Like a screw could be just slightly medial. It looks okay on the x-ray, but it's slightly medial. It could be compressing a nerve. So it's difficult to diagnose complications sometimes. It's difficult to diagnose non-unions. I mean, you get a CAT scan, it's hard to know if it's healed or not. People have adjacent degeneration. People have chronic infection. So they have back pain. It's hard to diagnose a chronic infection. You just have to be suspicious. And the implants can be loose, and you just can't tell on the CAT scan on the x-ray. And the other thing with spine is that there's many options, and maybe you do the wrong thing. Do you do an anterior surgery, do a posterior surgery, do both? I mean, that's where experience and knowledge of all the different surgeries you can do comes into play. Because maybe it was the wrong operation for the problem. So I'm wrapping up. I know it's long, but this is me. I looked much better when I was younger. And Ricardo, Ricardo Restrepo, who practiced in Colombia, and Ron DeWald. And Ron DeWald always told me the 6 P's of surgery. Proper preoperative planning prevents poor postoperative outcome. So here's a big thing: is like you cannot go into surgery cold. You got to know every single step that you're going to do, because if you don't do that, you're not going to do well. And then the other joke he always used to say is the Christopher Columbus operation, never to do in spine. So Christopher Columbus is you don't know where you're going, so you're not sure what the problem is in the first place. You're just doing an operation. When you get there, you don't know where you are. So in other words, you're at the wrong level, and then when you get back, you don't know where you were. So you had no idea what you were doing, why you're doing it, where you were. It's just bad surgery. So that's all I have today.
Very good.
Do you have any questions? Spinal device failure?
Comprehensive talk.
Any questions about spinal device failures or anything?
No, it's just hard to know what's a good implant. You guys have a lot of different options, and
a lot of it's how you're trained, your experience. Yeah.
About certainly high risk people are hard to get a good result. Heavy people, obese people, not surprising they get implant problems. The spine is a tough organ to fuse.
Yeah. All right. Thanks for coming.
Good talk.
Hold on, let me turn it off.
Nice.